We are going live, doctor.
Yeah.
7, 6.
Good evening, everyone. It's a pleasure to have all of you here. And I must start by thanking LifeCell and SFM for making this webinar possible. I'm actually feeling a bit weird because whenever I go for a conference, I usually log into FB and say, I'm traveling to Chennai, Hyderabad, so FitoCon, MustCon, or something like that. And usually it's something big for me to post on FB. And this time, I couldn't do that because I couldn't write on FB. I'm traveling to my living room to just give a talk on FGR. But jokes apart, I thank each and every one of you for coming here. I know in spite of it being a Saturday night and in spite of it being a COVID lockdown period, you have a lot of options. You have a lot of options of, sitting down, having a nice margarita, having pasta and watch Netflix and probably tuck into some great divine honey nut crunch ice cream. So I know you have a lot of options. So thank you for coming. And whenever we talk about FGR, we are always obsessed with size. And if you like sci-fi movies, I want you to imagine this. I want all of you to imagine this. Imagine you go to sleep tonight and you get up tomorrow early in the morning and find yourself 20 years back. You've got up in the past, 20 years ago. And then you go for your clinical practice and you find that all your colleagues and all your friends are now screening for Down syndrome, but they're screening only mothers who are greater than 35 years old. And you will argue with them. You will tell them that that's not the way to screen for Down syndrome. You will tell them that Downs, yes, there is an increased risk in women above 35 years, but everyone is at risk. The majority of women that are going to have babies with Down syndrome are going to be born to the younger age group. And therefore, you have to do universal screening, but nobody is going to believe you. Now, fast forward to the present and think about what are you doing in fetal growth restriction. In fetal growth restriction, all of you are arguing that if the baby is less than the 10th centile, then alone there is a possibility of fetal growth restriction. And we are screening and trying to find out growth restricted babies only in that subset and forgetting that there could be growth restricted in the so-called AGA babies. And here's the clincher for all of you. 70% of the babies that die at term are not going to be SGA. They're going to be AGA babies. And one of the biggest problems against progress in science is basically our resistance to change. We continue to do the things that we are doing and we resist or fear the unknown, thinking that change would probably not be for the best. And that's why I want to start off this slide with this quote from a very good friend of mine. You're always one decision away from a totally different life. Let that sink in. And that decision is to take on change. Now, when we look at growth restriction, there are two parts to this. The first part being to make a diagnosis of growth restriction, and the second part being on how to manage growth restriction. So part one is what I'll be dealing with today. And if I don't bore you to death, you can come back for part two, which is on management. Now, when it comes to diagnosis, the first and most important thing is to define the disease that you're studying. Unless you define it, it is not possible for you to find it. And to define it, you have to first know the tools for diagnosis. And there are two important tools that we have so far, and those are growth charts and Dopplers. So when you define growth restriction, you should also know the definition of SGA. Now, the biggest error that we make is that we think FGR babies are always going to be present in this subset of SGA babies. Now, SGA and FGR are totally different things. Now, first of all, let us try to understand what SGA is. SGA, or small for gestational age, is basically a statistical definition. Whenever a baby falls less than the 10th centile in any kind of a reference chart, we would call that baby SGA. As you can see here on the screen, you can see a bell-shaped curve. Now, this curve you get when you look at the normal distribution of weight of fetuses across countries, across states. Wherever you are, if you take the birth weights or the ultrasound estimated fetal weight of all the fetuses, you will get this sort of a curve, where a majority of fetuses are going to be in the center, and there are going to be a few to the right or to the left of the curve, but still they will be normal. And it is this curve that translates into graphs. And here, the same thing you can see, there is a 5th centile, there is a 50th centile, and there is a 95th centile. So you would call a baby SGA if it falls less than the 10th centile. It is as simple as that. But there is a problem here. And the problem is, which chart do I use? If you look at the number of charts that are available, there are more than 83 published fetal growth charts. And the 10th centile in each of these charts are different. At 36 weeks, the AC can range from 276 to 292 millimeters. What that means is that if you have a baby with an abdominal circumference of 280 millimeters, it is going to be above the 10th centile in the chart that uses 276, and therefore that baby is not going to be SGA according to that chart. But if you use a chart that uses 292 as the 10th centile, then according to that chart, that baby is SGA. And at term, the difference in weight between all these charts would be as high as 345 grams. It's a huge problem. So which chart do we use? Let me give you an example. I'm going to show you one patient, and I'm going to show you different charts and show you how this baby's weight figures on each of these charts. The first one will be a population reference chart that we commonly use. The second one is a WHO, the third intergrowth, and the fourth Hadlock. Now, the population reference chart will look something like this. If you look on your screen, you can see that the AC is growing well. It is at almost close to the 50th centile. The estimated fetal weight is also close to the 50th centile. This baby is growing well, is what all of you would say. Now, if I look at what you see on your machine, what do you see on your machine? On the left side of your screen, you can see that the gestational age is 34 weeks, 3 days. The estimated fetal weight is 1917 grams. And on the right side, you can see that the weight is well within the 10th centile. It is above the 10th centile, below the 50th centile. This is exactly what you saw in the graph before. One important point that I would like to stress here is that please do not look at the gestational age that you get based on your biometry. If you look at the biometric estimated gestational age, you can see that it is 31 weeks plus 6 days. So there is a lag of around probably 2 plus 3 weeks, and that is of no use for us. We need to know based on the chart whether it is less than the 10th centile or not. So according to this population reference chart, you can say that the baby is above the 10th centile, is growing well, and therefore does not SGA. But let us look at another chart. This is the same patient, same gestational age. This is a Hadlock chart, and Hadlock is saying that this fetus has got SGA because that fetus has got a weight of around 4.6 centile. It is the same fetal weight, but on this chart, it is at 4.6 centile. Let us look at the other chart. Intergrowth, same weight, and look at where the estimated fetal weight is. It is at 12.3 centile. So intergrowth is saying that this baby is not SGA as yet. The WHO chart again says that this is SGA and that this baby's fetal weight is at 4.1 centile. So which chart do you believe? There are 4 charts here. 2 are calling this baby SGA, 2 are calling this baby AGA. So which chart do you believe? But actually, if you look at it, this is a pseudo method to treat IUGR. If you find that you do not like one chart, and if you find that the baby is less than the 10th centile on one chart, just change the chart. Once you change the chart, it's no longer FGR, and you can be happy, the patient can be happy, everyone's happy because they do not have to crack their heads on how to proceed further. And that's why it's important to understand what each chart means and which chart would be the best for your patient. So when we look at charts, there are 2 basic types of charts, a reference chart and a standard chart. And let me take you through these charts. A reference chart basically has 2 types, a live birth reference chart and an ultrasound estimated fetal weight reference chart. Now, what does a live birth reference chart do? Now, live birth reference chart looks at the actual birth weight of babies that are being born across gestations. For example, if I want to take a live birth weight reference chart of the state of Kerala, I would go around all the medical colleges and see what is the birth weight of babies being born at all gestations at 22 weeks, 23 weeks, 26 weeks, 27 weeks, 30 weeks. And all these gestations, I would collect the birth weight of babies being born and I would create a chart for all these babies. Now, what is the problem with this chart? This chart should be good as any other chart because you're looking at actual birth weights. But the problem with this chart is that babies that are going to be born preterm are not normal babies. These are babies that are going to be born to mothers with preeclampsia, or they may have malformations, or they may have PPROM or infections, or they may even themselves be IUGR. So what happens is that when you make a chart based on live birth weight, your population is going to have a huge chunk of babies that are going to be smaller as you proceed further and further away from term. As you become close to 30 weeks, 32 weeks, 28 weeks, as you proceed more and more preterm, these babies are going to be smaller and smaller. And so what happens to the 10th centile? The 10th centile is going to be lower. And when the 10th centile is lower, what happens? You will miss out on SGA. So we are never going to use a population reference chart based on birth weight. This is what we commonly do. We use a reference chart based on ultrasound estimated fetal weight. Now, what is being done here is that you're going to use ultrasound estimated fetal weight of all the pregnant women who come into your OPD. For example, if the All India Institute of Medical Sciences or JIPMER decides to make a reference chart based on ultrasound, what they can do is they can tell their fetal medicine unit to start taking ultrasound measurements of all pregnant women who come into their OPD and make a chart based on the gestational age for all of them. So what you will have is, you will have an ultrasound estimated gestational fetal weight chart for all these mothers. But here also there is a problem. And the problem here is that the population that comes to a hospital will be a mixed crowd. They're not going to be entirely healthy. You will have mothers who are malnourished, mothers who are having preeclampsia, you will have babies that are having fetal growth restriction, and therefore you will have a mixed population. And if you're taking the ultrasound estimated fetal weight from a reference center, for example, if you're taking it from our center or from any of the premier fetal center units that are there across the country, what is going to happen? There is going to be a referral bias. The patients who are going to come to a referral center are more likely to come to a referral center if they have some issues with their pregnancy. And therefore, an ultrasound estimated fetal weight reference chart based on a mixed population will have a lower 10th centile. And because of that lower 10th centile, again, what is going to happen? You're going to miss out on SGA babies. So that brings us to the standard chart. And what does a standard chart do? A standard chart is looking at what would be the growth potential of a baby if a baby is growing under perfect environmental conditions. So what is being done here is that, like in all these charts, Hadlock, intergrowth, or the WHO charts, what is being done here is that they are identifying healthy pregnant women. That is the first step. Healthy pregnant women in the perfect environmental conditions, and they're following up these pregnancies till term with ultrasound at regular intervals and trying to create a chart. Now, let me give you the intergrowth example. Just an example. I'm not supporting the intergrowth or the WHO or the Hadlock, but I'm just giving you an example on how a standard chart is made. Now, what the intergrowth people did was that they looked at 8 different geographical locations all over the world, and they picked out healthy, well-nourished pregnant women. They had a standard weight, a standard BMI, they had proper nourishment, and then they looked at the ultrasound estimated fetal weight of all these pregnancies. And guess what they found? They found that it doesn't matter whether you're born in the United States or in Kenya or in Oman or in India. It doesn't matter where you're born, your graph is going to look exactly the same. Your 10th centile, your 50th centile, your 95th centile is all going to look the same. So what does that tell you? It tells you that ethnicity is not the reason why these babies are smaller. It is a surrogate marker for socio-economic status. If you're looking at the women that come into your hospital on a regular basis, you would find that majority of them are undernourished or malnourished. And that is why these babies are small. And if you take that as your criteria for normalcy, what you're going to do is you're going to set up yourself for failure. And that is why it is important to have a standard chart. Now, if you are really worried about ethnicity and you want ethnicity to be a factor, you can make an Indian chart. But if you want to make an Indian chart, you have to make an Indian chart in the proper way. That is, you have to go to each state, find out ideal, pregnant, healthy women in the perfect nourished state, and then follow up those pregnancies to term and then make an ultrasound estimated fetal weight chart. Now, if you are able to do that, and then if you are able to have the 10th centile, the 50th centile, and the 90th centile of that population, then you would have probably ruled out on ethnicity. But I suspect that if you do that, you would find that your charts would be exactly similar to that of a standard chart, and probably the only difference would be in the femoral length or in the height of these babies. But apart from that, all these babies would follow the same trajectory. So my first message is, if you want to pick up SGA, that is not growth restriction, SGA, babies that are less than the 10th centile, use a standard chart. Now let us try to define FGR. The biggest error that we make in FGR is that we derive the definition of FGR from SGA. We say that for FGR to happen, the baby has to be less than the 10th centile along with some Doppler abnormalities. Or the baby has to be extremely small, less than the 3rd centile, without any Doppler abnormalities. This is how we are defining FGR right now. But that is not the definition of FGR. The definition of FGR is a functional problem of unmet fetal need. When any fetus fails to reach its genetic potential, that is when we know that baby has got fetal growth restriction. So it is not about size, it is about the inability of the baby to reach its genetic potential. Now, is that possible? Is that possible for a baby to not reach its genetic potential and still be above the 10th centile? Let me give you a few studies to really elaborate that. This was a study that was done in UK. And what they did was they looked at their birth registry and looked at the stillbirth rates in a large population, around 69,000 pregnancies. And what they found was that it was really astonishing. And this is what they found. And this is from where I got my numbers from. If you look at this graph, what you can see here, you can see there is a yellow box and there is a blue box. And in the yellow box, it shows that majority of your preterm stillbirths are small babies, SGA babies. They are growth restricted, they are small, that's fine. But 70% of your term stillbirth babies are not SGA. They are AGA babies. They are babies greater than the 10th centile. So these are the babies for whom you would do a scan and you would probably say that the baby is growing well, there's nothing wrong, everything is fine, and you will let them go and probably they will end up in stillbirth at term or close to term, or even worse, would be an intrapartum event which would cause fetal distress, fetal demise, or maybe even cerebral palsy. And this is another study from Netherlands which again proves that point which I'm talking about. What you're seeing here is on the left side, you can see of the curve, it is the left axis, you can see perinatal mortality, and on the x-axis, you can see birth weight centiles. And if you look at this, you can see that as the birth weight centile drops below the yellow arrow is the 50th centile. As it drops below the 50th centile, you can see what is happening. The neonatal mortality, the perinatal mortality is increasing exponentially and becomes extremely high when the baby's birth weight or centile falls below the 3rd centile. And so which is the ideal weight here? The ideal weight is between the 50th and the 90th centile. As soon as the baby drops below the 50th centile, its risk of dying increases and keeps on increasing. And yes, it is high after the 10th centile, but it is still high between the 50th and the 10th centile. Remember the Down syndrome example, what I told before. Down syndrome occurs, the highest risk is in the women who are greater than 35 years, but majority of your births are happening in the younger age group, and therefore we cannot ignore them. So what does this mean? It means size is definitely a criteria for preterm FGR or early onset FGR. But majority of your late onset or term FGR babies may not be small. And in late onset FGR, the smallness may occur as late as 36 or 37 weeks. And if you're not doing a scan at 36 or 37 weeks, you would probably do one at 32 or 34, and you would probably miss the bus altogether. And why does this happen? It happens because of the degree of placental damage. When the degree of placental damage is less, these babies begins to growth restrict later on, not at early gestations. And when they begin to growth restrict later on, they may be having growth restriction, but they will be still above the 10th centile. And that is why the 10th centile is something we cannot rely on, especially as we go close to term. So what is the way forward? The way forward is to understand that FGR can be present in two different subsets. The first subset being the baby less than the 10th centile, the so-called SGA baby. And the second subset would be in the AGA group between the 10th and the 50th centile. And we have to identify FGR babies in both of these subsets. And the tools that we use are the same. We look for signs of fetal compromise. We use Doppler and we use growth velocity and try to find out which of these babies are growth restricted. For that, you have to understand about Doppler first. And in Doppler, I have always said this before, we are looking at the answers, but we do not know what questions we are asking. The answers mean absolutely nothing unless you know the question that you're asking. And so in Doppler, there are two types of Doppler abnormalities. The first one are called as diagnostic markers of Doppler abnormalities, and the second one is called prognosticating markers of Doppler abnormalities. So in the first one, we use Doppler to make the diagnosis of fetal growth restriction, and in the second one, we try to decide whether we need to go for preterm delivery or not. The second part will be dealt with next Saturday, and today I'm just going to talk about the diagnostic markers of Doppler abnormalities. So in that you have three basic vessels, the uterine artery, the umbilical artery, and the middle cerebral artery. Now when you're looking at the uterine artery, we are looking at maternal supply. So as the pregnancy progresses, the maternal supply is going to get better and better. So the question we are asking the uterine artery is the supply good? That is the question we are asking. We're not asking about the fetus. We're not asking about anything else, but we're just asking, is the supply good? And for that, you have to understand that the placenta is a two-compartment organ. It has got a fetal compartment and it's got a maternal compartment. And the maternal compartment is the sinusoids that you're seeing that are filled up by blood that's coming through the uterine artery. And into this sinusoids, you find the placental cotyledons are floating and they are supplied by the umbilical artery. So you have two compartments, the uterine artery, which is the maternal compartment, and the umbilical artery, which is the fetal compartment. So the umbilical artery is telling you about extraction, whereas the uterine artery is telling you about supply. So what do you do if the uterine artery is abnormal? The uterine artery is basically used as a screening tool. So in the first trimester, if you find that the uterine artery is abnormal, it warns you that this baby could develop fetal growth restriction later on, and it also warns you that the mother could develop preeclampsia. It has got no role in surveillance because it does not tell you about the condition of the fetus. So you do not have to keep on looking at the supply again and again. It's not like your supply and chain demand, like if there is a demand from the fetus, the mother can increase the supply. That does not happen. You're looking at the supply once, and if the supply is bad, you know that there is a problem with supply. After that, you're going to concentrate on how good the fetus is. But apart from that, there is a very important use of the uterine artery. And that is when the baby is small, and if you find that the uterine artery is abnormal, there is a twofold increased risk of the brain Dopplers becoming abnormal at term. And that is important for perinatal outcomes. So if you find that the baby is small, at maybe around 32 to 33 weeks, everything is fine, the umbilical artery is fine, MCA is fine, CPR is fine, but the uterine artery is abnormal. It is a warning sign telling you that at term, this baby may have an abnormal MCA or an abnormal CPR, and this baby could have poor perinatal outcomes. And the second warning that it will give you is that when the baby is small and the uterine artery is abnormal, it warns you that this mother can develop preeclampsia. And this could be the kind of preeclampsia that occurs closer to term. The BP, everything might be completely normal right now, but you have to keep a close watch on this mother because this baby is small and the uterine artery is abnormal, which tells you that this mother may develop preeclampsia later on. The second vessel, the vessel that all of you love, the umbilical artery. Now, the umbilical artery is the vessel that looks at extraction. So the question what we're asking is, how good are you at taking in nutrients? That is what the umbilical artery is asking. And so when you look at the umbilical artery, you can find that as the gestation progresses, the resistance drops, the extraction becomes better because the baby's demands are more and the baby is pulling out nutrients for its need. So if you look at the graph, you would find that it progressively has a drop in the diastolic flow, an increase in diastolic flow, and definitely progressive drop in resistance. But the umbilical artery will become abnormal only if the placental damage is greater than 30%. So when the placental damage becomes greater than 30%, the umbilical artery will show signs of resistance. And as that damage increases to 60%, you will get absent end diastolic flow. And when it begins to reverse, that is when there is more than 70% damage to the placenta. Now, here is where I want you to understand the 30-70 concept. And what is the 30-70 concept? The 30-70 concept is that if you have placental damage that is greater than 30%, if you find that the placental damage is greater than 30%, the umbilical artery is going to be abnormal and the baby is going to growth restrict earlier on. Now, why does this happen? If 50% of your placenta is damaged, only 50% is available for the baby. So baby will outgrow the placenta much earlier and will begin to growth restrict as early as around 24 weeks, 25 weeks, and the umbilical artery is going to be abnormal. So what you're going to deal with here is early onset growth restriction. And what if the placental damage is less than 30%? When the placental damage is less than 30%, the umbilical artery will be normal, as I told you before, but the baby will begin to growth restrict in the third trimester. 70% of the placenta is available and the baby is doing fine, absolutely fine till around 30 weeks, 32 weeks. But at 32 or 33 weeks, the baby begins to growth restrict because now the demand is more and the supply is not good enough. And that is when the baby will begin to growth restrict. And here, because the baby begins to growth restrict at maybe around 32 or 33 weeks, it may be only around 36 weeks that the baby will fall below the 10th centile. And that's why it is so easy to miss out on late onset FGR. It is very, very easy to miss out on late onset FGR exactly because of this. But what if the placental damage is much less than that? Say, let's say around 15% or say 20%. Now here what happens is that the umbilical artery is normal. The baby will begin to growth restrict much later, maybe 36 weeks, 37 weeks, and will maybe never go below the 10th centile. So you have a baby that is around the 30th or the 40th centile, is not growth restricted according to your definitions because the baby has not fallen below the 10th centile. But this is the group, the AGA group of fetuses that are experiencing hypoxia, but you fail to pick it up because you have not looked at your Doppler. So what is the use of the umbilical artery? It is useful as a surveillance tool in growth restriction, absolutely good. But where it fails is in mild placental disease. And it is going to be normal in all cases of late onset FGR and also in term FGR babies that are not SGA. So when you are looking at the umbilical artery, a very important point that I would want to stress is do not look at absolute values. Put it on a chart. And if you look at the chart, you can see that it is going all over the place. It is going down, then it's going up, then it is coming down. This is because the umbilical artery is not something like, or any Doppler for that matter, is not something like a robust yes or no answer. It is influenced by hemodynamics. Hemodynamics of the baby. It could be because of the breathing movement of the mother. It could be because of hiccups in the fetus. So you're going to get variations. So what you need to look at is the general trend of the umbilical artery Doppler. And you can see that the trend here is that it is rising. And that is what you have to keep in mind. One measurement does not mean that the umbilical artery has become normal all of a sudden. And it also does not mean that the umbilical artery has become abnormal all of a sudden. Now, coming to the middle cerebral artery. Now, in the middle cerebral artery, the question you're going to ask is the baby hypoxic? Now, you're not looking at the placenta, you're not looking at the supply or extraction. Now, you're looking at the fetus and asking the question, is the fetus hypoxic? So, normally, the middle cerebral artery is going to show high resistance flow, and it remains high resistance throughout the pregnancy. And this is how the waveform would look like. But when the fetus begins to experience hypoxia, the centralization or the brain sparing reflex kicks in. And when that happens, you have dilatation of vessels to the brain, the heart, and the adrenals, the major organs that the baby is trying to save, and therefore you will have dilatation in the middle cerebral artery. And when you see that dilatation, you know there is hypoxia. And here again, the middle cerebral artery, you should remember, is highly susceptible to changes in intracranial pressure. So whenever you have hiccups or breathing movement, you can find that it fluctuates a lot. And that's why, again, it is necessary to plot it onto a graph and look at the general trend in which it is going. Is it going downwards or is it going upwards? And on this chart, you can see, even though there is a zigzag variation, you can see that the general trend of the middle cerebral artery pulsatility index is going downwards, which means that the resistance is dropping. But what is the CPR and why do we need it? Now, the CPR is basically used when you have near normal values of the MCA and near normal values of the umbilical artery. It is a highly sensitive marker for hypoxia, but it is not specific. It tells you that the baby may be suffering from hypoxia, but it cannot tell you with sure certainty. It tells you that be on the watch, this baby might have hypoxia. It is because when you use the ratio, that is the pulsatility index of the middle cerebral artery and the pulsatility index of the umbilical artery, and when you use their ratio, you find that it is abnormal. Because normally how it should be that the MCA pulsatility index should be higher, and therefore the ratio should be higher. Here again, you should not use absolute values. You should cross-check it with the gestational age and see if it is falling less than the 5th centile before you call it as abnormal. And an abnormal CPR tells you that this baby is probably having hypoxia. So it allows you to pick up hypoxia, but it does not allow you to know whether the baby is acidotic or not. So the question we are asking is very specific. To the middle cerebral artery, the question is the baby hypoxic? Not, is the baby acidotic and should I do preterm delivery? That is not what we are asking. We are only asking if the baby hypoxic. Now, the next question is growth interval and how do we use it? We talked about the first tool, Doppler, and we understood all about how it should be used. And the next question is growth interval. Now, it's very intuitive to think that if the growth interval is dropping, then the baby should be abnormal. If the growth interval is growing upwards, then shouldn't the baby be normal? It's probably logically to think like that, but that is not how the baby grows. Because normally, physiologically, every baby growth restricts to a certain extent as the baby reaches term. And that is the biggest problem in understanding growth interval. How much of a fall in growth interval is significant and over what time period? The Delphi consensus tried to answer that, and they said that probably you could say that when the fetal weight drops across 2 quartiles. Now, 2 quartiles is when it falls by 50 centiles. 1 quartile is 25. So when it falls by 2 quartiles, it has to fall by 50 centiles before you can call it abnormal. And what the Delphi consensus said that it should be present along with either of 2 criteria, that is the AC or the estimated fetal weight less than the 10th centile, or an abnormal CPR along with or with a uterine artery PI that is abnormal. Now, the problem with growth interval and the Delphi consensus was that if the baby is less than the 10th centile, the growth interval does not matter, because if the baby is less than the 10th centile and growth restricted, the Doppler will almost always be abnormal. And that was what was shown in this study by Edward Gretakos. If you look at this chart, you can see that it is dropping to less than the 10th centile. And if you look at this study by Edward Gretakos, you can see here, in this study, if you're able to read it, what they did was that they looked at more than 500 pregnancies and looked at the growth velocity. And when they looked at the growth velocity and also the estimated fetal weight, they found that in all those babies where there was this huge drop in the growth velocity and there was a fall of the estimated fetal weight below the 10th centile, the Doppler was already abnormal. So there was actually no specific advantage of using growth interval in those babies that are less than the 10th centile. But there is a use for growth interval in AGA babies. In AGA babies that are greater than the 10th centile, a drop as significant as 2 quartiles from the 80th to the 30th centile is asking for attention. It is telling us, please look at the baby. Please look at the baby. This baby has dropped down from the 80th centile to the 30th centile. So definitely something is wrong with this baby. And it is begging for attention. And that is why, if you look at the criteria in Delphi, also they have mentioned that if you have at least one of these two criteria, that is, if you have an AC that is falling by 2 quartiles, and if you have an abnormal CPR or a uterine PI that is greater than the 95th centile, then there is a possibility that this baby would be FGR. But this drop, again, has not been proved. There is no way to tell that if the drop is by, say, 40 centile or by 20 centile, it is not significant. So we are still in a gray area there. And so what most experts would suggest is that if you have a drop in your growth velocity, and if you have a baby that is between the 10th and the 50th centile, it would be worthwhile to put that baby under surveillance. And this is what is very important. So you have to understand that growth interval, when it is dropping, you have to be on your watch out for babies that are above the 10th centile. When it is less than the 10th centile, you do not have to worry about the growth interval. Most likely, the Doppler are going to be abnormal. So how do you diagnose FGR? Now we have done the background, and now let us try to diagnose FGR. The first thing I would want you to do is divide your babies into 2 groups. The first group would be those babies less than the 10th centile, the so-called SGA group. The second group would be those babies between the 10th and the 50th centile, the so-called AGA group. And let us start off with the SGA group. In the SGA group, there are 3 possibilities. You are either dealing with early onset growth restriction or late onset growth restriction or SGA. All these 3 babies will be present in the SGA subset. And our job is to find out which of these babies belong to which of these subsets. Now, the early onset growth restriction, as I told you before, the placental damage is going to be more than 30%. And that is the reason why this baby is going to growth restrict early. And therefore, the umbilical artery will almost always be abnormal. So if you have early onset growth restriction and you have an abnormality in the umbilical artery, most likely you're dealing with early onset growth restriction. That leaves us with 2 groups, the late onset growth restriction group and the SGA group. Now, in both these groups, the umbilical artery is going to be normal because in late onset growth restriction, the placental damage is going to be less than 30%. Now, all of you are fixed with this cutoff there. You always think 32, 34 weeks. I want you to remember that it is an arbitrary cutoff. It does not mean that if you find a baby that is growth restriction less than the 10th centile at 30 weeks with a normal umbilical artery, you will not call it late onset growth restriction. It could very well be growth restriction and it could very well be late onset. So you don't have to be worried about the gestational age. What you need to be worried about is how is this baby growing? What are the signs of hypoxia in this baby? That's what you should be worried about rather than labeling them as late or early onset growth restriction. So in this group, the umbilical artery is going to be normal. And how do you find out if this baby is growth restricted? You look for pathological signs of smallness. So when you're looking for pathological signs of smallness, first thing you would do is you look at the supply. How good is the supply from the mother to the fetus? So which vessel are you going to study? You're looking at the uterine artery. So you'll ask the question to the uterine artery, is the supply good? If it is bad, it means that is the cause of growth restriction. And if it is bad, that baby will have abnormal brain Dopplers towards term. And if it is bad, that mother can develop preeclampsia towards term. If the supply is good, then the next question you have to ask is the baby hypoxic? Because you know the extraction is okay, the umbilical artery is fine, but is the baby having hypoxia or not? So the next question is to the MCA. So you look at the MCA, look at the CPR, and if they are abnormal, it tells you that the baby is hypoxic. And if there is no signs of hypoxia, then the third thing is to look for smallness. If the baby is extremely small, if you remember the perinatal mortality chart that I showed you right at the beginning, the mortality becomes exponentially high when the baby falls below the third centile. So when you have a baby that is less than the third centile, then it doesn't matter whether the supply is good, whether the extraction is good, whether there are no signs of hypoxia, you would classify that baby as late onset growth restriction. So in late onset growth restriction, you would separate them out by looking at the uterine artery, but looking at the MCA or the CPR, and also by looking at the estimated fetal weight. So in the SGA group, you make the diagnosis of growth restriction by first looking at the umbilical artery. And if you find that the umbilical artery is abnormal and you find that this baby is growth restricting from earlier on, this is early onset growth restriction. The second thing that you're going to look at is you're going to look at the uterine artery and the MCA and the CPR and the estimated fetal weight. If either of them are abnormal, then you're going to classify them as late onset FGR. If all these things are normal, then you have a subset that is the normal small fetus, and these babies are then classified as SGA. Now coming to the AGA group. Now the AGA group is slightly more complex because this is the group that is still under research, and that's why people are always worried for making that change. Now I want you to listen to me very closely when I talk about the AGA group. Now AGA group is a baby that is greater than the 10th centile, and so in this group you're going to look at one, signs of hypoxia, two, you're going to look at drop in the growth velocity. Now when you're looking at a baby that is, say, maybe at around the 30th or the 40th centile, and you're looking at the growth velocity, sometimes you might not have a growth velocity chart available. You should always look at the MC and the CPR, and you would find that there may be signs of hypoxia. Now, when there are signs of hypoxia, there is a high chance that these babies could have problems towards term. And this was first put forward by Asma Khalil's group, where they found that if the CPR was abnormal, there could be a possibility of poor perinatal outcomes. So they suggested that CPR could be used as a potential marker to look at fetal growth potential regardless of the size. It seemed weird at that time and totally absurd to think that there could be an association between CPR and FGR when you're convinced that the baby is above the 10th centile. But then they did a retrospective analysis. They did a study of more than 14 lakh pregnancies. And it was a retrospective analysis done over a 2-year period. And what they found was that when the CPR was abnormal towards term, they found that when the CPR was abnormal, there was a higher chance of cesarean section for fetal distress. There was a higher chance of low cord blood pH at delivery, a higher chance of having low 5-minute ABGAR, and a higher chance of admission to the NICU. So what they found was that if the CPR was abnormal, and especially in those fetuses between the 10th and the 50th centile, now that's very, very important. They said that it was important only in that subset, not between the 50th and the 90th centile. In the subset between the 10th and the 50th centile, there is a good possibility that if the CPR is abnormal or the MCA is abnormal, there is a good possibility that any of these complications could develop. Now, it would be not fair on my part if I do not tell you studies that have come against this concept. And a majority of studies that have come against this concept have come from the Fetal Medicine Foundation, where they looked at CPR at 35 and 37 weeks. And they said that it was not a good predictor. But in their study, they very specifically said that there was an association. There was an association with an abnormal CPR and poor perinatal outcomes, but it could not be used as a good predictive tool. And they said that probably it would be useful if you use it closer and closer to the point of delivery. And then they repeated the same study in 2019. And what they did in 2019 is they looked at CPR and MCA values 24 hours before induction of labor. You can't get closer than that. 24 hours before induction of labor. And what they found out was that, again, there is an association, but it could not predict perinatal outcomes. Now, there is a problem with this study. If you go through the papers, you can understand that in spite of the fact that there is an association between abnormal CPR and an AGA fetus, they said that it could not be used as a good screening tool. And I think that is because of a number of confounding factors. And the first confounding factor is that they did not account for the problems that could happen in labor. Even normal babies with normal CPR and normal MCA could have intrapartum events which could affect the outcomes that they were studying. And therefore, that was the first and principal confounding factor in all these studies. And the second confounding factor is that they clubbed the entire AGA group into a single group. They clubbed all fetuses from 10th to the 90th centile in a single group, and they did not make a distinction between the 10th and the 50th and the 50th and the 90th. And therefore, it's obvious that between the 50th and 90th centile, you're going to get a large number of babies that are going to be absolutely normal. And therefore, CPR is not going to affect their outcomes because they are not growth restricted and they do not have a chance of poor perinatal outcome. And that is probably the reason why CPR, in spite of having a good association with poor perinatal outcomes, could not be used as a good screening tool because of all these confounding factors. But then that is still something that we need to assess on. But as a general clinical guideline, the best thing to do would be to remember that while looking at AGA babies, use standard charts and decide to put those babies between 10th and the 50th centile under surveillance, and also to look at the growth interval. If the growth interval is also looking abnormal, then the chances are much more higher that your CPR and MCA could probably predict poor perinatal outcomes. So if you're planning to do a really good study and you want to find out if there is a possible connection between CPR and poor perinatal outcome, the best method would be to combine both these parameters. Look at the growth velocity, look at the CPR, and then find out that subset of fetuses between the 10th and the 50th centile with an abnormal growth velocity and abnormal CPR, and I'm sure you will be able to find out those babies that are growth restricting and have a high risk of dying in utero. So does size matter? For all of you who are still awake and still there with me, does size matter? And my answer is no, it does not. What you have to remember is FGR exists in two different subsets. FGR can exist in the SGA group. It can also exist in the AGA group. In the SGA group, you can identify them by looking at Doppler, by looking at the estimated fetal weight. If they are extremely small or if they have Doppler abnormalities, you are looking at FGR. That is the easy part. The second part, but again, for that easy part, remember, SGA babies has to be less than the 10th centile. Use a standard chart, otherwise you will not reach the diagnosis of SGA. So use a standard chart, pick out SGA fetuses, and then pick out FGR in that group. And the second group of FGR would be those babies in the AGA group between the 10th and the 50th centile, where we are looking at growth potential. Here we're going to look at MCA, here we're going to look at CPR, and then we are going to look at the growth velocity and trying to find out if that growth velocity is going to be effective in allowing us to pick up fetuses with FGR in the growth velocity in the AGA group. Now that's about the first part. And I wish I had something really exciting to tell you so that all of you could come for part 2 on next Saturday. Something like this. I don't have anything even closely exciting to tell you like this so that all of you would come for part 2. But I have something else. I'm going to make a couple of statements, and I'm sure you might not agree, or some of you may agree or may think that it is controversial. But if you want to know why I am making these statements, you will have to come for part 2, and part 2 is listen to the fetus. And the statements that I'm making are, the DV flow is not a trigger for delivery after 30 weeks. MCA cannot be used for surveillance in late onset FGR. In late onset IUGR, Doppler is not a trigger for preterm delivery. And by picking up cardiac remodeling in a growth restricted fetus, we can provide treatment in the first or the second year of life and prevent adult onset lifestyle diseases. So it is important to look at cardiac remodeling in fetal growth restricted fetuses, as it allows you to make some modifications that will prevent this baby from having lifestyle or adult onset lifestyle diseases. I hope that is enough for you to decide on coming up here next Saturday. Thank you. Thank you for listening. I'm going to take questions, and if there are any questions, I'd be more than happy to answer them.
Uh, Doctor, there are already few questions on the Q&A part.
Yeah.
I'll answer them, Doctor.
Okay, the first question is, how frequently would you suggest growth scans for FGR? Now, the frequency of surveillance in FGR comes in the management part, which I'll be discussing on Saturday. But suffice to say that we would do it at 2 weekly intervals, at least 2 weekly intervals, because that is when you will be able to make a perceptible difference in your growth, not earlier than that. So that also is basically based on which stage of IUGR that fetus is and how frequently you would be doing a scan based on the stage. The second question is, some say that doing routine Dopplers in a normally growing baby is not needed. But as we know that in late onset FGR, size is not the problem. So should we recommend doing routine Dopplers whenever we do a growth scan? See, that is what exactly I told just now. Which chart you're using depends on is what makes you think whether you're dealing with SGA fetus or not. And therefore, I would suggest that if you find that the baby is between the 10th and the 50th centile, definitely do Dopplers. And when you're looking at Doppler, have an open mind to it. And remember that if the baby is between the 10th and the 50th centile, you're doing a growth scan. If you find that the Doppler is abnormal, you're going to flag it as probable FGR. But at the same time, if you have a baby that is growing at the 80th centile or the 85th centile, and if you find that the Doppler is abnormal, I would suggest that you repeat it before you actually call it as abnormal. Should we do routine Doppler scanning for screening for every ANC patient? Exactly what I'm saying. If you're only going to go by size, you're going to miss out on 70% of those babies who are going to die. The stillbirth at term are going to be your AGA fetuses. And unless you have a robust mechanism of picking up babies between the 10th and the 50th centile, you should do Doppler for those babies and try to find out if they are normal or not. How should we decide delivery in AGA fetuses? That again is a management question. So I want you to come on Saturday. So I'm not going to go there, but I will definitely cover that in the next session. What is the role of uterine artery Doppler as a screening tool for IUGR rather than preeclampsia? In preeclampsia, it is a good screening tool. And in IUGR, it is not so much so. Now, let me tell you why most of the screening mechanisms for IUGR have failed. Most of the screening mechanisms or studies have failed because they have not defined the disease properly. Because they're just looking at SGA babies. You're trying to look at the uterine artery, and then you're trying to look at SGA fetuses and trying to see a correlation. So you're missing out on a huge subset, that is FGR and AGA. And that is why most of the studies are failing in FGR, because they are not realizing that when you're looking at the uterine artery, and if you want to make a significant contribution, you should add in biomarkers and also include all those fetuses that are AGA and growth restricted. How does the PI in the umbilical artery have any significance? Low PI in the umbilical artery means you're looking at a good umbilical artery, so it is okay. You're having a good umbilical artery and the baby is growing well. It has not got any good significance except that the extraction is pretty good. It is not a problem. If the growth curve shows a downward trend on a chart less than 2 quartiles, what will be the next line? This is for one patient at 30 weeks, another patient downward trend at 36 weeks, both a normal Doppler. Again, the same thing. If you find that it is dropping 2 quartiles, I would suggest that you put the patient on surveillance. Put the patient on surveillance. Again, remember, when I'm saying surveillance, it does not mean to go in and do a preterm delivery. No. Put the patient on surveillance just as you would do surveillance for late onset growth restriction. You would look at them on a weekly once basis, add in all your, again, I don't want to go into the management part, add in all your tools and try to push the pregnancy as close to term as possible. Significance of isolated increased MCA-PI in the third trimester. As I told you before, MCA is very, very susceptible to hemodynamic changes. So you cannot look at the MCA as an isolated finding. You have to look at the growth of the baby, and then you have to look at MCA, and you have to do repeated measurements to be sure that you're actually looking at the correct value. Is it possible to have reversal of diastolic flow in the... Oh, I missed that. What is that question? 1 second. The questions are just popping up too fast for me. 1 second. Is it possible to have reversal of diastolic flow in MCA with normal CPR and umbilical artery at 36 weeks? Yes, you can get reversal in the MCA. Most common cause is when the baby is having a hiccup. You can find that the sudden increase in the pressures, and it can reverse. Also, when the baby is having good amount of breathing movements and the baby is breathing a lot, the pressures can fluctuate inside the brain, and you can have a reversal in the MCA, which is completely normal. So how to report AGA fetus with Doppler abnormality? This is the problem, basically. This is something that everyone has to wake up to. When we call a baby AGA, and when we find that there is a Doppler abnormality, you have to put that baby under surveillance. So you will have to say that this is a baby that is AGA and that has got a Doppler abnormality, and you would want to put it on surveillance, and you will have to communicate it to your referring clinician. And the problem is, even though we are waking up to this phenomena of having FGR and AGA fetuses, our clinical friends need to wake up to it as well, and then alone can we actually work together and try to prevent stillbirths. Is there an estimated fetal weight based growth chart for the Indian population? I'm not aware of a standard estimated fetal weight based growth chart. If you're talking about standard, of course, there are a number of reference estimated fetal weight growth charts. Now, as I told you, estimated fetal weight charts on a reference growth chart is done by reference centers. And in reference centers, you're going to get a mix of population that is high risk and low risk, and therefore the 10th centile is going to be lower. And therefore that is the problem of having those kind of charts. So as far as I know, I don't think there is a standard chart which looks at an ideal healthy pregnant woman and then follows that woman up to term and looks at the ultrasound estimated fetal weight. I don't think so. Aortic isthmus Doppler, yes, that is a question for next week, and I am going to, I think, be against aortic isthmus Doppler, so stick around for that on Saturday. Sir, which charts do you use? Okay, that's much closer to home than I would expect. I will tell you what I do. I use all the charts. Because I look at intergrowth, as you have seen in my slides. I've shown you all the charts. I look at intergrowth. I look at the population-based reference chart. And whenever I find that it drops in the standard chart, whenever I find that the baby's estimated fetal weight is dropping on a standard chart, I will put that baby on surveillance and put them on close follow-up. At late onset FGR, Doppler normal at 36 weeks, repeat Doppler at 2 weeks, makes it to term. Can we rely on Doppler then? I know it's coming next week. I'm sorry if I will answer all these questions next week, next Saturday, because I'm sure all of you will be again at home because this lockdown is not going to end anytime soon. So I hope I can see you all then. I will answer this question on whether we can rely on Dopplers alone. And I will just give you a hint here. When you're looking to decide on preterm delivery, especially in late onset FGR or also in FGR in the AGA fetuses, Doppler is not useful. You have to look at something that most obstetricians have always been using, and I will tell you that on Saturday. What reference charts do you use for CPR? You can use the charts that are available in Barcelona Fetal Medicine or the perinatology charts. Either of them can be used. How to diagnose FGR in a large GDM baby? Yes, that is a difficult question. It is extremely difficult because the babies that are greater than the 90th centile, babies that are having GDM, they could also be growth restricted if the mother has a vascular disease, and that is something that is almost impossible for us to pick up right now. And it is actually something that is in search of a protocol. There is no method but to just follow up GDM babies very, very closely with surveillance, proper glycemic control, and your CTG and biophysical profile. Would you say less than the 50th centile depending on USG findings or by plotting on customized growth charts. I purposely did not talk about customized growth charts because if I did, then probably this webinar would have gone on till tomorrow morning. Now, the customized growth chart, how it works is that it takes into account the mother's height, weight, parity, and then uses a mathematical formula and finds out what is called as a term optimal weight. And from that term optimal weight, it calculates backwards using a Hadlock regression formula and gets a 10th centile, 50th centile, and 95th centile for each mother. Now, a study was done in Sweden on this, and what they found was that it was exactly same as that of a standard chart. There was no difference because the odds ratio of height, weight, or ethnicity is not significant enough to create a difference in the centiles. So customized growth charts would behave exactly as that of a standard chart. But that's a huge debate, and let's not get into that. I would say that a standard chart is something that everyone can use with a complete ease. For AGA fetus, is there any role of uterine artery Doppler if the previous specimens are normal? Now, again, if you find that the baby is 10th and the 50th centile, we are still in a gray area here. 10th and the 50th centile, the only thing right now we can look at is the MCA and the CPR. And whether the uterine artery will be useful or not is something we cannot say right now, and currently it is not used in practice. Right now, the best thing that we have is to look at the CPR, MCA, and growth velocity. If the fetus shows more than the 50th centile, low PI of MCA near term, and normal umbilical artery is significant. See, greater than the 50th centile, as I told you, from most of the studies, they're saying it is not a good predictor. I think we could stick to between 10th and the 50th centile. Does USG, sorry, it moved up too fast. Does USG machine incorporate intergrowth chart? Yes, it does. The machine that we are using, GE machines, the Wollaston series, which we are using, does have all the charts. And what I've shown you right now is completely from the machine directly. Does amniotic fluid form a part of the assessment? No, amniotic fluid is not used for making the diagnosis of fetal growth restriction. Because if you're finding that the baby is small and the Doppler is abnormal, growth velocity is abnormal, so definitely amniotic fluid does not figure in there. It is an after effect of growth restriction, so it's not used as a diagnostic criteria. Is it necessary to do Doppler if the baby's fetal weight is consistently between the 50th and 95th centile? Again, I would suggest that we should be careful in the 50th and 95th centile because we don't have evidence in that group. And maybe you can skip, but between the 10th and 50th, almost definite. Which standard chart to follow to label SGA? Should we use one that makes the fetus fall SGA so that we are more cautious, or it doesn't matter, as you say, that we should look into the 10th and 50th group too carefully for lay? I would suggest that you use a standard chart because again, the 10th and 50th centile will be varying across different charts. Why AGA can be still FGR? Kindly explain quickly, not used to it, so taking time to sink in. I'm sorry, this webinar will be recorded and I will try to make sure that you people get a copy of it. So I don't think there will be enough time to talk about it. Fetal acidemia comes next week because acidemia is the biggest marker for preterm delivery, and so that will come next week. Can falling trend in AC alone be used as a tool for FGR? AC falling is an important tool, but cannot be used in isolation. It has to be either or. And of course, it is something that you should be careful about because AC can fall alone in certain other conditions as well. But estimated fetal weight is the best tool. Sometimes only MCA is below the 5th centile and everything else is normal. I missed that question. Everything else is normal. So why is the baby hypoxic when the nutrition is fine? Again, MCA does not work alone. It has to work in conjunction with your estimated fetal assessment. I remember you saying when you did my anomaly scan 1.5 years back, there is no use of it now because no intervention. I don't remember what you say. I don't know whether you are an IVF patient or not, because if you are an IVF patient, most of you would be on aspirin, and now only we have got this screening tool which tells us that uterine artery is good and it decreases. And so we have also started screening based on the uterine artery only after the aspir trial has come out. So yes, probably 2 years back I would not have been doing that. If growth scan is normal at 32 to 34 weeks, then should we repeat should we repeat at 36 weeks? Yes, we should. We should is what I would suggest, because again, I will talk about that next week, because you can miss late onset FGR if you do not do a repeat scan at 36 weeks. Does gestational diabetes, gestational diabetes mellitus BP TSH lead to FGR? Hypertension, yes. Diabetes mellitus, yes. If it has got a vascular problem, yes, it can lead to FGR. What is the significance of, one second, let me see how much time we have. Yeah. What is the significance of SD ratio? Should we consider that while making? No, SD ratio is no longer used. We use only the pulsatility index, because the diastolic flow, when it becomes 0, S by D becomes infinity, and therefore it will not give us any value. So it's a theoretical thing, but we always use PI. Difference in early onset FGR and late onset FGR by looking at umbilical artery flow. Yes, because the umbilical artery flow is going to be abnormal in late onset, whereas in early onset it is going to be abnormal because of the 30-70 concept that I just told you. Sometimes the umbilical artery Doppler trace is very good with good diastolic flow, but the MCA shows good diastolic flow with decreased PI and RI. How to proceed? Again, do not use in isolation. Look at the growth and then decide whether you want to use it or not. Do these charts follow the same sequence? Always uterine followed by umbilical, then MCA? No, there is no sequence. See, the sequence is, again, in late onset FGR, there is no sequence. The uterine artery may be abnormal, the umbilical artery may be normal, and the MCA may be abnormal. In early onset growth restriction, you can get a sequence with the umbilical being abnormal first, MCA, and so on. But in late onset and term FGR, that does not work. Sir, which growth chart do you use? I already told that about the growth chart. Any relation between Liker, AFI, and AGA? Does placental thickness imply anything? See, AFI, as I already told you, cannot be used for diagnosis. Placental thickness, yes, sometimes it tells you that there could be a cause like infection, or it could be triploides, which is leading to growth restriction, and that makes you think in that direction. And even in uteroplacental insufficiency, sometimes you can get a thick placenta. What's your take on Barcelona calculators? How useful is it in population? I told you I don't believe in Indian, American, Japanese, Spanish population. I believe that everyone is equal and should have the same sort of chart. And therefore, if you're using the Barcelona calculators, I would say they're absolutely fine. Please explain the role of MCA, Doppler, and CPR and AGA fetuses with growth. I'm sorry, that's already been covered, and I hope there will be a video recording of this that you can see. How do we report an isolated abnormal diastolic flow in MCA with AGA? And again, isolated abnormal umbilical one depends on which centile it is. If it is between the 10th and the 50th centile, I would be worried and would call them back for more frequent follow-up. If there is reversal in MCA 34 weeks with no reversal in MCA, as I told you, I've already covered that. Sir, while doing Doppler, I see normal and continuous wave pattern, but I see a lot of variability in numbers of PI and RI. Where am I going wrong, and which PI should I always use PI? And the variability you're seeing is because you're looking at a hemodynamic thing. It's not something constant. So as the baby moves, or as the baby has hiccups or breathing, all these things are going to change. Should we follow a single chart or change the chart as per each case? No, you can use a single chart. I would suggest that use a standard chart. You no need to have multiple charts. It's good to have one chart, but use a standard chart. Can we differentiate between hypoxia and acidemia on Doppler? Yes, we can, but that's going to come up next week. How to predict the risk of stillbirth in macrosomic babies? Macrosomic babies is a totally different topic, and I'm not going to go there. Kindly repeat FGR in GDM large babies. I'll do that again. Where can we find the reference ranges for PI in all the arteries? It is present on your perinatology.com, Barcelona calculators. So many are there. Sometimes I've come across smaller fetuses in GDM. How do I? Yes, small fetuses in GDM mothers on insulin is possible, and you have to follow them up as you would follow growth restricted fetuses. Does taking umbilical artery PI near the placental end and the fetal end affect the CPR? If so, what to do if it is abnormal? Again, what we do is we try to take the free loop. But again, you should remember, take multiple measurements and also regress towards the mean. That means you take the lowest possible value that you get and stick to that. Is AC less than the 10th centile with estimated fetal weight above the 10th centile is SGA? We're only looking at estimated fetal weight. AC, yes, it means that we should put this baby under surveillance, but estimated fetal weight is what we should use. Please explain the meaning of late onset FGR and significance. That was the whole talk. I think you will have to get a copy of the recording. Can causes of decreased movement or no fetal movement always be picked up by color Doppler study? Fetal movement is important. I'll tell you why next week. Certain genes responsible for FGR. Yes, genetics is a very important cause of FGR. I have not gone to that because we've had a lot of talks and webinars on that. Definitely, you have to rule out genetic causes. But if you have a baby with clear-cut signs of uteroplacental insufficiency, then to have a genetic cause is extremely unlikely. What's important is MCA 26 to 30 weeks. MCA is not used in early onset growth restriction that much because at 26 to 30 weeks, they will already have brain sparing, and we are looking at sequential progression. So the MCA and CPR are rarely useful for early onset growth restriction, but again, that will come in part 2. So I guess that's all. I don't think there are any more questions. Can we wind up, Varun?
Yes, doctor. If you are done with the questions, we can definitely.
Yeah, I think we have. And thank you so much for coming and listening. And I hope it was useful. And I hope I can see all of you next Saturday. Thank you. Thank you so much.
Thank you, doctor. Thank you.